Okay, we are live. And we are recording. ¿Qué tal? Buenas tardes, ¿cómo están? Soy el doctor Marco Álvarez, médico radiólogo. El día de hoy estamos con el doctor Juan Pablo Dueñas, el doctor Esdras, y vamos a iniciar este Zoom. En esta ocasión tenemos como invitado al doctor Agua Park. Estamos dentro de las actividades de Thyroid Virtual 2020. Thyroid Virtual es la respuesta académica de Thyroid Fest. Thyroid Fest es un grupo internacional interdisciplinario que tiene como objetivo impulsar la salud tiroidea. Somos un grupo de endocrinólogos, radiólogos, patólogos, médicos cirujanos, médicos nucleares e incluso pacientes. El día de hoy, ante las circunstancias mundiales por el COVID-19, decidimos migrar nuestra plataforma educativa presencial hacia una plataforma virtual y es por eso que estamos el día de hoy con ustedes. Dentro de nuestra aula virtual en Thyroid Virtual 2020, hemos compartido en el transcurso de esta semana charlas con respecto a la versión por radiofrecuencia y lectura de interés. Quiero darle la palabra a mis compañeros. Juan Pablo, ¿cómo estás? Juan Pablo.
Hola, listo.
¿Cómo estás?
Bien. Hola Marco, ¿cómo estás? Martín, ¿cómo estás?
Buenas
My
noches.
friend, Dr. Awan Park. It's a very, very, very pleasure for us being here with you. It's an honor for us share your friendship and your knowledge in this kind of lectures. So thanks so much for being here with us. Martín, welcome. Bienvenido, mi amigo.
Gracias. Gracias a todos los que están ahora conectados en esta noche, donde esperamos disfrutar bastante con el conocimiento en tiroides.
Dr. Park, how are you?
Yeah, how are you? I'm fine, doing well. Good evening, everyone. Yes, good to see all the familiar the faces and also some, the audience, who I cannot see, but it's really a great honor to be invited for this wonderful meeting. Thank you so much to all.
So let me introduce you to our friends throughout Latin America that are here with us today. El Dr. Park es un radiólogo tiroideo, particularmente con interés en el área de intervención. Él se entrenó en Seúl, en Corea, y actualmente es radiólogo en la Universidad de Virginia, en el Departamento de Radiología Intervencionista. Es un amigo de Thyroid Fest, nos ha acompañado ya en nuestras reuniones en Mazatlán, en Medellín, y el día de hoy estamos con él, pues, escuchando un poco acerca de esto. Va a presentar algunas diapositivas de interés, que son una pequeña revisión de lo que vimos en la semana en el aula virtual de Thyroid Virtual, y posteriormente vamos a tener una breve charla con respecto a algunas preguntas que nos han sido enviadas por el público. So, Dr. Park, the screen is all yours. If you want to share the brief presentation that you had for us, and then we'll go to the questions and answers. Okay. Please, all
Great,
yours.
Thank you. Yes, let me show you my first slide, okay? Slideshow, here you go. All right. So can I share the screen with the audience?
Yes, of course. At the bottom, there's a green a green square that says share screen. You just click on it, and then whatever you have on your screen, it'll pop up in everyone's computer.
Okay. Let me see. All right. I think there you go. Screen. Am I allowed to share the screen? Share the screen. I think you are the inviter, so host of this meeting. So I wonder, I have authority to.
So now you do. I've just you can.
Oh, share. Okay. Can you see my slide, or yes or no?
Not just yet. You have to click on the screen in your computer.
Okay. Wait a second. Sorry, but I cannot see the green box or click But even with that, I do not have any kind of screen set to share the screen.
If you can,
Yeah.
send us a presentation via email and send it to me, and I will make sure that it appears on the presentation. In the meantime,
Oh, that'd be great. Yeah, that's the one of the great thing. Okay, wait a second. Just in case, I should do it earlier, but I will send the email right now, Q. Okay, just wait.
Okay, good.
Okay, good.
Bueno, mientras arreglamos esta situación técnica, Juan Pablo, la ablación por radiofrecuencia en Latinoamérica ya se empieza a hacer. Se ha hecho en México, en Brasil, en Colombia. Recientemente tu grupo, junto con Esdras, empezó a hacerla. El doctor Luis Felipe Sánchez platicó con nosotros hace unas semanas acerca de tanto la ablación química como la ablación con láser, la ablación particularmente por radiofrecuencia. ¿Cuál es tu visión como cirujano? ¿Qué opinas de todo esto? ¿Es una moda? ¿Es algo que realmente es útil?
Pues mira, yo pienso que esto primero que todo no es nuevo, como ya lo hablamos con Roberto Novicio hace 2 semanas atrás. Estos son unas técnicas emergentes que no son nuevas, que esto es lo más importante de todo, que ya tienen una trayectoria donde se han podido evaluar tanto sus resultados a corto, mediano y largo plazo. Pienso yo que en este momento tienen una gran cabida para el tratamiento de muchas de las patologías tiroideas benignas. No sabemos aún las malignas, yo pienso que es un poco apresurado, es una opción. Pienso que es una opción viable para pacientes con microcarcinomas papilares que tienen contraindicación quirúrgica indiscutiblemente, pero no es la primera línea de tratamiento ni de elección para ninguna enfermedad maligna. Pienso que sí se va a convertir en la primera línea de tratamiento de enfermedades nodulares benignas, nódulos grandes, sintomáticos, bóceos incluso multinodulares que puedan ser susceptibles del abordaje por este método. O sea que es una técnica que ya tuvo su curva. Tenemos los resultados al día de hoy de su efectividad, de sus tasas de recurrencia que son bajas dependiendo pues del tipo de tratamiento que realicemos, y yo pienso que es una tecnología que llegó para quedarse y falta mucho y vamos a tener que hacer mucho con ella, yo creo. Tenemos que aprenderla, definitivamente tenemos que entrenarlos, tenemos que entrenarnos todos, tenemos que conocer, tenemos que leer y tenemos que hacerlo.
Bueno, aquí tenemos una pregunta del panel. El doctor Enrique Mainero de la Ciudad de México nos pregunta quién. Es algo que vamos a tocar más adelante, doctor Mainero. De hecho, hay un par de artículos interesantes en la literatura actual. Dr. Parr, were you able to send the email?
So I can able to share my screen now. Sorry,
Okay.
I'm ready now. So can you see my screen?
No, not yet.
Oh, I see now the green box. You cannot see my green box.
Click on share screen, and then you will see another screen.
Multiple screens.
Just click on your PowerPoint and then click on share, and that's it.
Yeah, actually, I have a multiple screen. So let me see this one, right?
There you go.
Yes.
Excellent.
Okay.
Got it.
Thank you. All right. Thanks for patience. Okay, let's get started. Okay. Again, I really appreciate for your very kind invitation. So I got topics from Marco in advance. So I think we are advanced. These all the 6 very essential topics in thyroid ablation. So I prepared a little bit of a not that long, but I just give 5 or 6 slides for each topic. And then if you don't mind, we like to discuss, and then I like to have a Q&As. Is it okay?
Yes, of course, please.
Okay. So the first topic is what is RFA? RFA is, as you know, it's a high frequency alternating. Sometimes it's called oscillating electric current. It's usually between 200 and 1,200 kilohertz. So if you going to put a monopolar electrode, if going to put a needle in our thyroid, it's connected with a generator, and then we are going to put this the grounding pad we are making a electric circuit in our body. So that's the concept of the thyroid ablation. So then you can ask what's happening, around the needle tip, especially around the active needle tip. So I'd like to explain about that with a more very nice, the images. So the basic one is there is ions in our tissue, and then like the potassium and sodium like that, and then where there's a alternating electric current, these ions will have agitation. It's a dipole vibration, another way it is called. And then when the ions are vibrating, the heat energies are heat is generated. So from the low temperature and body temperature and high temperature above 40 Celsius in degree, it will happen in the tissue. And then the heat generation equation is like that. So this is a very microscopic situation happening in the tissue. But if you see it more grossly with the naked eyes, let's say this is a thyroid nodule, and in the centrally, the highest temperature above 60 degrees, gradually this heat is transmitted by conduction, not convection. Convection means, through the air, something like that. By the conduction, heat is gradually transmitted from central core to the periphery. So the tissue reaction, if you see more details, above the 45 Celsius degree, there's irreversible cellular damage. Above the 50 in Celsius, that is ideal temperature. More than 60, there's an instantaneous, the cellular death happens by protein coagulation. So, and one of the things I like to explain about is initially you will see the vaporization of the water molecule by the heating, but gradually it loses the water component. We call it desiccation. And finally, it will be turned into the carbon, like a charring, and then so that's what happening in our body. So this is the example, and then it's cows in the liver, and then if you put a needle activity, electric current is transmitted from central to the peripheral. Gradually heat is transmitted and it will be heated and coagulated. As you see in the central around the needle, you can see the carbonization. And then gradually carbonization will surround the active needle tip. Then it will block the electric current. Also, it hinder the transmission of a temperature from central to the periphery. That's why, in other words, there's impedance will picked up. That means electric current, it will be dropped dramatically. So to prevent that, actually tip of needle, there's a circulation of cold, chilled saline. So we need this kind of peristaltic pump, and then we circulate this needle continuously to prevent such a charring or carbonization. So, and then definitely we need the grounding pad. Always this electric current should exit through the least resistance, which is connected with the machine. So this is the body, and especially thyroid nodule. And then you should understand that our body is kind of a resistant material in this electric circuit. And then your target is, to maintain high current density around the needle tip. That's why high temperature above the 50, 60 is, the heat is generated around the needle tip. All right, that is my basic concept about what is RFA. All right.
Okay, so it's pretty clear what is RFA. So, but the question, Dr. Park, let me say it in Spanish first, and then we'll say
sure,
it.
go ahead. Yeah.
¿Por qué tendríamos que usar la ablación tiroidea por radiofrecuencia? Why should we use thyroid RFA? Why?
It's a thermal ablation to kill the cells. Kind of usually benign, malignant, the cell, we make a there are many ways we can kill the cells. One is increasing temperature. We call it thermal ablation. Another one is we can use the ethanol like chemicals. So we call it chemical ablation. Another way using the temperature is we can use the cryo nitrogen. We can drop the temperature below the much sub-zero, and then we generate environment that cells not survive. That's why we wanted to kill the cells, yes.
Okay.
Dr. Park, but we have very good surgeons like Juan Pablo. Why we prefer, or why we should prefer one of these new techniques instead of ask Juan Pablo to make a surgery to our patient?
You mean the why you need this one, even to surgeons?
Yeah.
Okay.
Be careful.
Oh, all right. I have a more slide later on. Okay, it's early, but yes, definitely. The basic idea about this kind of it's kind of a minimal invasive surgery, but yeah, we can call it non-surgical, the method or tool. So as you know, in most in thyroid nodules, they are benign. Okay, so according to the statistics in the United States, 2/3 are benign nodules pathologically. That means after surgical thyroidectomy, if you analyze all the statistics, 2/3 are benign. That means we are doing a lot of surgery instead of, yes, in addition to malignancy, we are also doing thyroidectomy for the benign nodules. So, and then the idea starts from like, okay, benign nodule is only cause, cosmesis, like a cosmetic effect. And it's not definitely indicated for this kind of procedure or surgery. But most commonly, it has a compressive, kind of some compressive symptoms like a choking or foreign body sensation. So, swallowing difficulty. So, and then idea is if we can control the volume, I mean, we can achieve volume reduction of the benign nodule efficiently, I think then we can avoid the surgery. That's why now we are more directed toward non-surgical method like thyroid RFA.
Okay. Dr. Park, talking about of the complications of the procedures,
Yes.
During thyroid surgery, unilateral surgery, the major risk is the recurrent laryngeal nerve injury.
Mm-hmm.
And with a surgeon with a very good experience in surgery and thyroid surgery, the number is very low. Almost 2 or 3% of the recurrent laryngeal nerve lesions. Most of them are transit lesions. Which is the number of the recurrent laryngeal nerve lesions for radiofrequency ablation?
Yes, thank you for mentioning about that. As I know, 7% sometimes just very experienced surgeon like you, 2 or 3%. Yes, I agree with that. So according to the research for this thyroid ablation, about 1%, less than 1%. That means 1 out of the 100 patients will have voice change, not paralysis. So different from surgical injury. Surgical injury is more of the traction, during the operation, right? And then thermal injury is possible by, cauterization, but more of the traction, mechanical injury. But in thyroid RFA, it is thermal injury. So it's a different degree in grade. So if you see the statistics over 90 days, most voice changes are recovered, gradually, spontaneous. That means, even it is 1%, 1 out of 100 patients will have some voice changes or weakening, but they recover, mostly. So, and then acute complication is, you can say it is major complication about 1%, but really most of them are gradually recovered within 3 months. So that means it's almost like a less than 1%, close to 0. Yeah, complication wise.
Thanks so much. Martin?
Sí.
Well, I have a question. So basically what I gather is that it's not that RFA is going to take over surgery's place, but there's an ideal patient for RFA and another ideal patient for surgery. And then to my question, ¿cuál es el paciente idóneo para ablación por radiofrecuencia en tiroides? Who is the ideal patient for thyroid RFA?
I think thyroid ablation is not panacea. I mean, it did not solve the whole problem. So let's say patient has kind of a huge, thyroid nodule in one of the glands, whatever on the right or left side. Okay, it's already size-wise more than 5 or 6 cm. The volume is more than 50 ml, right? And then it already have some compression, compression symptoms. And then in that case, maybe we can think about hemithyroidectomy, lobar thyroidectomy, and then we can preserve the other side. And then with a very careful surveillance, there's a there's a new lesion, or there's existing one, but it's a tiny one. In that case, maybe we can control the, on the other side with the thyroid RFA. So the most serious kind of issue with this or kind of downside of this thyroid RFA is really the volume is large, the more than 4 or 5 cm. We need multiple sessions, and then there's chance for recurrence from the untreated, marginal portion of the tumor. So I think that we cannot treat all the benign tumor 100%, with this. According to one of the surgeon in New York, she mentioned about maybe 1/3 of the benign nodules population, very like a single nodule, or well positioned, located, and then without any risk factors like injury of the nerves. Maybe, but we'll see more. But I think some patients are like, especially in the United States, I mostly see multinodular goiters, So then at the end, the surgeon recommended, oh, let's remove because there's too many, too large nodules. And then they came to me, and then it's really, for me, it's really helpless, And then so I tried to hit the largest volume nodule, but the tumor nodules will grow continuously. So to me, multinodular goiter is really very, very challenging, especially with the large volume ones.
Dr. Martin, please go ahead.
I'm a endocrinologist, then I'm very interested in patients with hyperthyroidism for multinodular goiter with autonomous functional nodules. Do you think that is a good option to use radiofrequency ablation in this kind of patients with hyperthyroidism?
Yes, I actually have treated a couple of patients with the multinodular goiters, but one of the or a couple of nodules are hyperfunctioning. So they're okay with the multinodular goiter. Other nodules are multiple, but they, do not cause any problem. But among the nodules, and then one is hyperfunctioning. If we do a nuclear scan, we can know exactly which nodule is functioning. So if we treat it, and then we can, functionally, we can control the thyroid nodule. Yes, I think that is, kind of could be indicated, for thyroid RFA or thermoablation. Yes.
Okay,
Dr. Park, I have a question.
Yeah.
Oh, carry on, Juan Pablo, please.
Okay, sorry, Dr. Park. Do you have experience with another techniques for ablation, like a microwave or laser?
Actually, no. I use the microwave for liver or other, the tumors, like the kidney tumors. But I have no experience using other modalities in thyroid ablation.
Okay,
Yes.
and do you think that radiofrequency is better than laser or microwave?
Okay, so I do not have experience, but I did some research and read many papers and articles, for the comparison of the LA laser and microwave and HIFU, like
Yes.
So laser was first developed in Italy, Italian group. So laser is using the pulling back. If you see you can check how to do a laser ablation of thyroid nodules in YouTube. And then also I visited one of the clinic, and then I saw that they usually put the 20 gauge needle, and then advance the laser in a fiber, and then pull the needle a little bit backward, and then they actively on the power of the laser, they pull the needle and the optic fiber gradually. So that's why the laser ablation technique is a pulling back technique. They need the guidance of the needle. So in 2000, I can 12 or 13, there's a report with the laser ablation. So in that report from the laser, in small nodules, the laser or the RFA, it doesn't matter. Both are good because they're burning the small area, but it's enough without any moving shot technique. Just even it's a fixed technique, we can burn the tumor volume like a 1.2 cm, the nodule completely. But when the tumor volume, nodule volume increases, like more than 20, 30, 40, 50, as I mentioned just before a little bit earlier, like a tumor recurrence, the issue, then you should put the needle from corner to corner. Especially you should try to control the peripheral portion of the tumor. So that means, just pulling back, one or two pulling back of the laser, the energy or electrode is not enough. In that case, you should put the needle to, all the kind of unit, from, one section to another section. That's why, according to that, kind of paper, large volume, there's more efficacy from RFA rather than laser. I think rather than energy resources, I think the issue is more of the technique. But even with the laser, let's say you can put the 20 gauge needle from corner to the corner, and then you do the pulling back multiple times. I think that we can achieve similar result, like RFA. So there are debate like which one is better. Okay, mainly laser is better, laser frequency is better, but there's many factors we should think about that rather than energy resources. So, and the patient, that has a different tissue characteristics. And some nodules are has more water, or some, the nodules are more fibrotic, the component. Also depending on the operator's, experience. So I think it's hard to have a really prospective controlled study. So I have a slide of a prospective control study. According to that report, there's no much big difference. But one report said that, okay, laser is a little more volume reduction. Another report said like RFA has a more volume reduction. So I think you can use any kind of energy, but the most important is the concept of a thermal ablation and how you can protect important structures, especially nerves, and then how you can achieve enough volume reduction. I think that should be our goal. I think any kind of energy resources you can use, if you are familiar with. I think you're not, but you should have or maintain the same or less, standard complication rate. Let's say your complication rate is higher than others, or you cannot achieve enough volume reduction than others report. That means there's something, there's some issue, and you should find out what you should develop more in the future. So I mean, most important thing is clinical efficacy in volume reduction wise, and like a less recurrence. Another thing is a safety. And as we discussed, it should be better or the same than complication rate by surgery. So I think the clinical efficacy and safety is two key issues rather than what kind of energy are you going to use. Yeah.
Thank you.
Mm-hmm. I have a question. So, Dr. Park, are there any absolute contraindications, and can you also comment regarding minor contraindications? Let's say, can a patient with a heart device, like
Pacemaker.
a pacemaker, can they undergo thyroid RFA?
Okay, actually, there's no, I think, an absolute, contraindication. So this technique can be used for malignant and benign, but you should weigh the risk and benefits. Okay, there's a more damage and harm than benefit. We should not start. So then you can ask, what is the harm for this thyroid ablation? Yes, definitely complications or side effect, unwanted result. So the most serious one is, the nerve damage. So that's why you're not quite, but with the training, I think you can avoid the nerve damage injury. You can reduce the dramatically. So if you see the right corner of my slide, I don't know, you still can see it or not. The relative contraindication is really a patient is pregnant, or patient has a severe heart disease or pacemaker. There's a lot of debate even with these patient groups. Some people say we can do it, some people say we cannot, but it happens. It's kind of 100% or zero, and all or nothing. There's no between. So in that case, we can use the bipolar probe. It's already developed by companies. So if you use a bipolar probe, the same like some bogey, used in the operating room. So then the electric current is from the tip, to tip. So, and then there's no chance that electric current will flow to the electric, the grounding pad. Even you don't need the grounding pad. So I heard that this is already developed, used, but in the United States, it will launch it within this year. It will take some time, but I think pretty soon you'll get this, the bilobar electrode. Then I think pretty much there's no contraindication. So another thing is already the patient has contralateral side, not your target side, focal cord palsy. But if unluckily you make a nerve injury, the patient will have a bilateral, focal paralysis, the kind of cord paralysis. That is also, you're very carefully, it's well done. You can avoid the nerve injury. Yeah, it could be indication. So there is no absolute, the contraindications. Let's say there's a coagulopathy. Yes, before surgery, we can correct coagulopathy with FFP, fresh frozen plasma, and infusing the platelet. So yeah, if you aware of, aware of the potential complication, if you know how to respond appropriately, I think there's no absolute contraindication.
Dr. Park, in that case that the patient has a previous laryngeal nerve injury in the contralateral side of the ablation, do you think that is important, the localization, the nodule inside the thyroid gland?
Mm-hmm.
And why?
Oh, sorry. Sorry. Would you?
In that case, with a patient with have a previous vocal fold paralysis in the contralateral side of the procedure, don't you think that is very important, the localization of the nodule inside the thyroid gland?
Yes, and then you should do all your effort, to protect, your target, the recurrent laryngeal nerve or vagus nerve on the target side, right? And then like a hydrodissection, very slow, kind of, the needle pulling and advancement with the start with the very lower energy. And another option is, it'll be costly, pricey, but you can do the vocal cord monitoring. So as I know, the intubation tube, there's a sensor, right? So some centers, they do vocal cord monitoring. So maybe in that case, it's better to monitor the vocal cord during the thyroid ablation. In that case, yes, definitely you need a general anesthesia. You cannot do it under IV or consultation or with a local NOMI only. Yes.
Okay.
Doctor, I have a question. In this kind of cases, difficult cases, the use of glucose for dissection and to try to have a very good delimitation of the nodule, do you think that it's a good idea and can help us to avoid to make a damage in the tissues around?
Yes, there's many different ways we can protect, the vagus or vocal, the recurrent laryngeal nerve. So already a device like a uniphase electrode is developed. That means, you can only, one side of the needle, there's actively, it can kind of create electric current. So, but you can burn almost like a burning, only one side. It's a uniphase electrode. Another ways, as you mentioned, you can use the hydro dissection, but I didn't put slide much in this, but Dr. Bang, he proposed, a dangerous triangle, but according to the surgeon's textbook and experience, or it's a real anatomy. The right side is the recurrent laryngeal nerve is hooked by the subclavian artery. So the recurrent laryngeal nerve actually run more from the obliquely, on the right side. So I like to propose, rather than on the right side, especially rather than dangerous triangle, I like to offer dangerous zone, because especially in middle, lower portion, middle 1/3, lower 1/3 of thyroid gland, and so the recurrent laryngeal nerve travels, from the anterior ladder, and it traveled to the posterior medial. So I realized that even I didn't close to the, I was not close to this triangular concept, dangerous triangle. I experienced some voice changes, something like that. So the concept of hydro dissection is you can put a lot of D5, or mostly D5 is much better than the normal saline, because it doesn't have any ions in this. So, and then if you dissect here around the nodule, especially close to carotid artery sheath and trachea and esophagus, between the nodule, and then you can just put a distance and then hold the D5, we can absorb the energy, and then you can indirectly protect the nerve. But even with that, energy is too high, nerve is too close, or you can damage the nerve. So hydrodissection is one of the way, but sometimes even with that, your needle is too close to the nerve, and then you lost the track of path of your needle, and then the nerve damage also can happen. So there's a many factors. The most important is the ultrasound, the needle tracking technique, and then your kind of assumptive, kind of a idea about where's a kind of a potential nerve damage. I think that is most of the two important key factors in preventing complications.
So, Dr. Park, a couple questions from the public. Regarding a thyroid nodule, when can we certainly say that a thyroid RFA was successful? What percentage, what shrinkage do we usually have? 20, 30, 50? What is the ideal percentage that we can achieve doing thyroid RFA on a nodule?
Okay, so, and then we should go back to then, the initial symptoms. Why patient visited your clinic, why came for thyroid ablation. So, and then we can divide into two groups, right? And the one is the functionally okay, but it's a mass effect. The second thing is regardless of kind of a size or volume of the nodule, functioning nodule, right? So mainly we are talking about the non-functioning nodule. So let's talk about the non-functioning nodule. For the non-functioning nodule, there's two issues. One is a mass effect, another one is cosmetic issue, cosmesis. So, and massive, really patient came to you with a mass effect, and you should reduce the volume of the mass. We call it a cytoreduction volume. The cell's volume, you should reduce it. So, but very interestingly, when tumor nodule is small, diameter is 1 cm, 2 cm, volume is really kind of the very small. But when the tumor nodule, the grows more than 3 and 4, the volume increases exponentially, not linear, very exponential, right? So let's say volume is 1, then we can diameter is 1 cm. We can multiply 1 by 0.524. That means it's a 0.5 cc, but it increases to 2, and then it's almost like a 4, right? And then 3 and 4, the volume 32, and 5 is very dramatically. That's why patient came to you, and then if even you have a 50% volume reduction for the 5 cc nodule, let's say 5 cc nodule, if you have a 50 cc volume reduction, 50% volume reduction, the nodule is still 4 cm. Then patient could not feel any big improvement. Okay, I visit you with a 5 cm nodule, and after your treatment, I have a 4 cm nodule. That's why 50 cc volume reduction in tumor oncology, it's kind of a clinical therapeutic success. But I think 50% of volume reduction is very arbitrary, but it's a big kind of volume reduction in oncology, especially malignant tumor. But in the benign tumor, I think 50% is sometimes not enough, especially volume is larger than 3 or 4 cm. So in that case, patients should have enough volume reduction to remove, the elevate, their improvement, to have improvement of their symptoms. So function in other, definitely there's a 2 criteria, right? And then thyroid function should be converted to euthyroid. That means the function should TSH, T3, T4 should be normalized. Another thing is, thyroid scan, the background uptake, and then the hot nodule changed into the cold nodule. I think that should be our goal, a reasonable goal. Yeah.
So a couple more questions from the public. One, la voy a decir en español primero. ¿Es un paciente con un adenoma paratiroideo puede ser candidato para ablación por radiofrecuencia? So the question is, can a patient with a parathyroid adenoma be a candidate for this kind of procedure?
Okay, parathyroid adenoma is a very, especially secondary, because a lot of renal patient, the end-stage renal patient, chronic renal patient has a parathyroid in a secondary hyperfunctioning, and also patient can have a primary secondary adenoma. So we can do it technically, but according to the surgeons, not by me. And then they say, if I were you, I wouldn't do the ablation. The reason why is because especially the recurrent laryngeal nerves are very close to the inferior pair of, a pair of parathyroid glands, especially in the inferior one. So in that case, we need a lot of hydrodissection. Really, we should make a parathyroid glands floating, in the island. So there's a report of the parathyroid, the ablation, especially in Japan, injection of the ethanol into the parathyroid gland, especially in the secondary, hyperparathyroidism is routine. They have their own protocol and guideline. Their goal is just the normalize the function, but because underlying disease is still there, like a renal failure, renal chronic disease, that's why they should repeat. That's why back and forth. So there's a early report from the Sloan Kettering. They also did ethanol injection or some ablation of the secondary hyperparathyroidism, but it is not a kind of a permanent kind of a treatment options, but more likely symptomatic, approach, just control the volume and that, like that. Yeah.
I have a question from the surgical point of view. For secondary hyperparathyroidism, especially in the renal patients, during surgery, we have to perform at least 3.5 parathyroidectomy. So that means that we have to remove 3.5 glands. If we want a very good result or successful with ablation, we have to perform ablation at least of 3 glands. What do you think about it? And you have to see at least 3 glands before the ablation.
You mean surgery? I read that surgeon do some harvest half or 3 parathyroid gland and leave the 1, right? So your
Yes,
question
and leave at least 1 or half a 1.
Okay, half of 1. Okay.
Yes, this is very different in the primary hyperparathyroidism secondary to a single adenoma,
Yes,
because it's
very
a single
different.
gland.
Yeah.
But in secondary hyperparathyroidism, we have to remove at least 3 glands.
Yeah. So that's why for the parathyroid ablation or mostly chemical ablation reported from Japan. So I think a parathyroid gland ablation is still it's underdeveloped, but I think personally we should do more, but there are only few the experience reports about parathyroid kind of gland ablations. Yeah, adenoma maybe single nodule.
Yes, this is another disease.
Yeah.
So I have a couple questions, Dr. Park. One from the public is, what is the rate of recurrence on a thyroid nodule after treatment with RFA? Is that depending in the size of the nodule?
Sorry, what's the incidence rate of what?
Yeah, what is the rate of recurrence of a thyroid nodule after treatment with RFA? Is that depending on the size of the nodule?
Yeah, if you treat thyroid nodule, usually we can achieve 60 to 90%. Average, I like to say 82% volume reduction. So what will happen is after really you treat it well with a single session, okay? Single session, the nodule volume is less than 20, okay? Then you really treat it well, experienced. You should have over 6 months, you should have a 50% volume reduction over 6 months. And then if you wait another 6 months, you will have a 20-30% more volume reduction. That's why average wise over a year with a single session of the nodule less than 20 cc, you should have a 70-80% volume reduction. That is the standard around the world. And then untreated portion now remains, the 20%, right, or 30%. But 20-30% of 2 cc nodule, 2 cm nodule, 3 cm nodule, 3 cm nodule, 4 cm nodule, or 5 cm nodule in diameter is totally different. The tumor size, nodule size is bigger, and then even you say you 70-80%, I think a lot of person remain untreated, and then it will quickly have a marginal tumor regrowth and recurrent. So it's hard to say, like if you give very specific tumor nodule, and then you can say how much it will develop. But the general principle or thumb of rule is the larger the volume or the larger the diameter is, I think that it has a more chance for recurrence. So according to the long-term follow-up, I think 10 to 20%, up to 30%, maximally you can have a tumor recurrence, especially not the first year. In first year, whatever you do, at least you have a 50% volume reduction. That's why after long-term follow-up, like a 2-year, 3rd year, 4th year, between 2 and 4 years, and then you have a more chance for tumor recurrence. So one of the things I like to emphasize today is benign ablation, thermal ablation of the benign nodule in thyroid is just after one single the thyroid ablation, you should continue the kind of a nodule tumor surveillance, to check that there's any increase of the tumor nodule in size of the nodule. That is one of the downside. But if you're really good and then if you repeat the second session, and then really you can control the tumor 80 more than 90%, I think the chance for recurrence is very less, unlikely, and then you have a very nice long-term follow-up. So You can satisfy the patient within 6 months, a year, but more important thing is you should reduce the tumor volume more likely under control. Otherwise, you will see your patient every 2 or 3 years. That's the kind of the practice happening in the world. Yeah.
So another question from the public is, are there any biochemical changes in the patients after RFA ablation? I mean, do they go to hypothyroidism?
No, actually not. The reason why is this tumor thermal ablation is concept is under treatment. Really, even you're a word-on expert, but you cannot overtreat it. If you overtreat it, you will cause complication and you burn, the damage the normal tissue. So if you do the more cases in practice, you will understand this is under treatment. That's why the chance for this procedure will cause, functionally hypothyroid is very, very unlikely. Yeah.
Okay. Well, Dr. Ezra, do you have any other questions?
Yes. I would like to know about malignant nodules. I think that the malignant is a big, tricky thing. Then I would like to know your opinion about to treat malignant nodules with this kind of techniques.
Yes, and in the malignant nodules, we can divide it into the two categories. One is recurrent, thyroid cancer, and thyroid bed or lymph node metastasis in the latter compartment. Another one is a primary, thyroid nodule. So for the advanced groups, in Italy and especially in Korea, they're moving into the recurrent thyroid cancer or metastatic nodule, and then now collecting data in primary thyroid nodule. But as you know, especially for the primary thyroid cancer, it's very notorious for the early lymphatic spread or intragranular microscopic metastasis. So, but if you for the primary tumor, only for the group like we are doing surveillance, that means without surgery, just the follow. It was a good concept, but according to the strong Catholic Japanese, the early group for this surveillance, but they lost a lot of patients, and then some of them had surgery. So that means, if really patient is reluctant to have surgery or not surgical candidate with their comorbidities, but it is not bad idea to intervene and try to control the primary tumor. For the metastatic or recurrent thyroid cancer, surgeon can at least once, twice, they can do repeat surgery. The more they do, I heard there's very challenging anatomically and technically. In that case, really, the recurrent cancer is this thyroid ablation can be used as for a concept like a palliative or volume, more of the kind of a reduction, in addition to chemo or hormonal therapy or the radiation therapy. We can reduce the volume, and then you can combine with other treatment modalities, and then you can improve the patient quality of life. It is not a radical curative treatment. We can use this thyroid ablation as adjunctive, as the method to improve patient quality of life.
Dr. Park, do you think that ablation could be the first option for surgery for micropapillary thyroid carcinoma in the future?
Yes, especially low grade, papillary, the carcinoma. So Dr. Peck recently group in Korea, they published 133, patient numbers, and then they reported the result. So in that report, I just summarized it here. I don't know, you can still share the slide or not. And then last year, they did the RFA of the 133 patient in 152 nodules, and then follow-up period is really short, and even it's 6 months, complete disappearance was observed in 91%. It is really kind of some jaw dropping. It's amazing result, but 6 months is not enough. You know, thyroid cancer should be lifelong, you know, follow. You know, I saw that thyroid cancer recurs, you know, even 10 years, 20 years. So I think this is too short. You know, that the follow-up is too short, but that is it is early to call it a success, but early result is not that bad, you know. So it really, especially cytology-wise, it is a low-grade, you know, papillary the carcinoma. Also, size is very important. So with evaluations, you know, it's better to surgeon concept is have a surgical margin, you know, enough. That means, you know, they want to over-excise, you know, the leaving the healthy tissue. So I think it's the same, you know, tumor nodule is really big. Yes, micropapillary low grade is, yes, concept wise, you know, less than 1 cm, and the small ones it'll be, and then even without the moving shot technique, if you use the 7mm 1 cm active tip needle, you know, even with a fixed needle technique, without moving the needle back and forth, you can burn, you know, cross the tumor and even leave it over the normal tissue, and then you can completely, I think, ablate the tumor. So I think a low grade micropapillary could be, you know, primary, you know, the option, you know, for thermal ablation could be a primary treatment option. Yeah.
Thanks so much.
Quisiera tomar unos minutos, bueno, unos segundos, por favor, a las gentes que nos visitan, que están inscritos en el curso Thyroid Virtual 2020. Ellos tienen en su pantalla del registro de Zoom una pequeña encuesta. Por favor, ayúdenos en estos últimos segundos dándole clic en la respuesta que ustedes consideran la prudente para ustedes. Yo tengo una pregunta muy importante para el doctor Park antes de irnos a casa. Y quisiera tener un pequeño comentario de Juan Pablo y del doctor Esdras. Doctor Esdras, ¿tú cómo ves esto? Desde tu punto de vista como endocrinólogo, ¿cuál es el futuro de la ablación para radiofrecuencia tiroidea?
A mí me gusta, a mí me parece apasionante, me parece que hemos manejado la mayoría de los nódulos desde un punto de vista quirúrgico. Y el manejo quirúrgico implica anestesia, hospitalización, muchas veces costos, y si algunos de estos, no todos obviamente, algunos de estos nódulos que hoy en día manejamos desde el punto de vista quirúrgico, podemos tener un acercamiento no tan invasivo, yo creo que es una muy buena alternativa. Eso para la población en general, pero si tú lo miras también en las poblaciones de alto riesgo de cirugía, para ellos sí que es cierto que es una buena alternativa. Estamos corriendo menos riesgos. Obviamente lo digo, no es para todos los nódulos, pero sí para algunos en especial. Yo creo que es muy promisorio y yo creo que en la medida en que vaya siendo más asequible, que vamos teniendo más conocimiento, va a ser todavía mucho más la confianza que vamos a tener en este tipo de procedimientos.
Juan Pablo, y desde el punto de vista quirúrgico, ¿hay un futuro? ¿Coexistirá con la cirugía?
Absolutamente, pues mira, o sea, yo soy cirujano y tú y yo lo hablamos hace mucho tiempo, veníamos casi 2 años persiguiendo esta tecnología, 2 años, si mal no recuerdo, Marco, donde yo pienso que hay situaciones que, a ver, yo como cirujano, Martín me conoce, trabajamos juntos, yo para llevar un paciente a cirugía me lleno de razones para llevarlo. Y si tengo una opción que tenga unos resultados casi iguales que la cirugía, hablando de complicaciones y de tasa de éxito del resultado, hombre, tenemos que tratar de ser lo menos invasivos posibles. O sea, yo pienso que lo que te dije al principio, la terapia ablativa de los nódulos tiroideos, del hipertiroidismo secundario a un nódulo único funcionante. No lo sé el hiperparatiroidismo, yo todavía no estoy seguro, pero solamente con estas 2 circunstancias ya tenemos para tener un buen campo, aumentando el tratamiento que yo pienso que sí se debe hacer. Si nosotros tenemos un microcarcinoma papilar de tiroides y lo vamos a poner en vigilancia activa, que es muy contradictorio, pues hombre, hagamos una vigilancia realmente activa, quemémoslo y miremos qué pasa. O sea, y eso sí, siendo muy estrictos con la selección de los pacientes que se les va a hacer, porque definitivamente la vigilancia activa no está hecha para población joven, tiene que ser pacientes mayores, el problema es definir mayores, pienso yo que son mayores de 60 años y con comorbilidades que contraindican el procedimiento quirúrgico.
So, Dr. Park, would you like to share with us your take-home message? What is your view on thyroid IRFF for the future?
Okay, so this is maybe my last slide, and then so already this thyroid ablation is I don't know, you are still you're doing this practice every day or not, but it's already in other countries and other it's tool for other physicians. So as do it or not is only totally depend on you. Really, it is really helpful. You think it's a promising, and it really is good for the patient care, especially from benign nodule to potential of the primary malignant or the recurrent, the cancers. I think it's really initially it's hard to access because you should have some kind of a skill for ultrasound, the tracking of the needle, and then also you should a little bit know about the machine and some equipment tools. But if you have, there's a definitely learning curve, and then you need at least 10 to 20 cases, without any big complication, major complication. Then if you overcome that barrier, I think this could be a very nice tool. It doesn't matter whoever you are, like a surgeon, yes, you can really triage the patient, you can do the surgery, then you can do the, this one, endocrinologist. Okay, even they do not do the surgery, before sending the really surgically indicated patient, you can really take care of the patient without surgery. So I think even the radiologist, me, I'm doing this. So the more really, our goal should be what is the best benefit of patient, and then really in any situation, this could be helpful in patient care management. I think it's better to have this tool, rather than just watching and listening continuously. We have great tutors and instructors, so you can learn from them, close by you. Yeah.
Finally, learning curve. How many cases?
Oh, excuse me?
Learning curve. How many cases do you have to perform to acquire a correct learning curve?
Oh, you mean to be comfortable with? So most importantly, I recommend at least 10 to 20 cases. Even you cannot have an instructor always next to you, but at least you need the planning. You have a pre-discussion or pre-planning with someone who knows very well. But for the 5 or 10 cases, I like to recommend someone is next to you who has more experience than you. I think that would be great. The reason why is there's something you can miss, even you have a very thorough training through the web or hands-on, but there's some variations, right? So that's why I like at least at 5 or 10 cases, you can have a very nice kind of supervisor. I'm more of the person who can help you next to you. That would be great. And then it's common sense. You feel like, oh, I'm comfortable, I can go by myself, and then you can have your autonomy. And only very challenging cases, then you can discuss more, do very carefully. I think at least I like to recommend 5 or 10 cases. You need the self-confidence. Be confident, start with a small achievement. That's why if you have a very challenging situation and then you have a complication, your confidence will drop dramatically, and then it's hard to move forward, right? So that's why before reaching that point, definitely I like to connect, everyone, like this very wonderful meeting. It's very important to have connections and help each other. Yeah.
Thank you.
Thank you. I have a couple comments. Well, first of all, Dr. Park is very humble, but I would like him to share with us about his projects for teaching this procedure in the United States and the Americas. And I also would like to thank the presence of Brian Alexander. Thank you, Brian. I know it's Saturday morning in Korea, in South Korea. Thank you for being here with us.
Hi, Brian.
Well, yes, thank you for being here, Brian. Dr. Park, tell us about thyroidablation.net.
Yeah, so I ran 2 or 3 websites, but now only I maintain thyroidablation.net. So now I have a plan to open thyroid ablation the training website, whatever you call it, Thyroid Ablation Academy, Thyroid Ablation School. So, and pretty much soon I like to open that website, and then instead of this kind of, in addition to this kind of very nice, interactive meeting, I hope I can provide very detailed, like, okay, so what's more kind of facts, and then I like to develop more of your comfortability and skill sets. So all the slide what I showed could be one single topic, and for each topic I can spend 20-30 minutes, and then with a more kind of discussions interactively, and then so let you make more comfortable, have confidence before starting your first or second case. I'm very happy if you forward your any pending cases, and then if you want to know access, like what is the best, and I like to share my experience step by step. My goal is let everybody whoever wants have this tool, let them take it. I think it is not a challenge. That's why Dr. Peck trained the surgeon, the general surgeon, not endocrine surgeon, general surgeon, endocrinologist, also radiologist around the world. That means everybody can do it, even you can do it. But only the thing that you should start is, so you should have this thing in your mind. Okay, I want to take it, I want to do it. Then that is a starting point. So I like to open all the website information into everyone, to make it available, anytime, any place. That's my plan project.
Yeah, there's a pretty neat article this month published in Austria regarding who should be doing it and why. But anyway, quiero agradecerles a todas las personas que estuvieron presentes el día de hoy con nosotros. Tenemos público de América del Sur, tenemos gente de Chile, de Argentina, viéndonos tanto en la plataforma por Zoom como en el live del YouTube. Tenemos gente de Brasil, tenemos gente en Corea del Sur, en Estados Unidos, en México, en muchas partes, obviamente, Colombia, que son Thyroid Fest, es así como que colombo mexicano, ¿no? Les recuerdo, somos un grupo académico internacional interdisciplinario, endocrinólogos, radiólogos, patólogos, cirujanos endócrinos, médicos nucleares, pacientes, y estamos en este mundo con el objeto de impulsar la salud tiroidea. Dr. Park, thank you very much for being with us, and thank you again for all your support in the past and in the future, and we look forward to share with our people your book once it's published, and we'll look forward to help you translate it into Spanish.
Okay, thanks so much, everyone. Have a great Friday evening and weekend. Thank you.
Thank you. Thanks so much, dear friend. Martín, muchas gracias.
Muchas gracias a todos.
Adiós, Juan Pablo Esdras, que estén muy bien. Buenas tardes, amigos.
See you later.
See you later. Alligator.